Thank you to all of you for coming. Hopefully this is going to be a beneficial evening for all of you, and the talks have been excellent so far, and hopefully I can at least make the grade. Okay, so erectile dysfunction. No matter how you say it, no matter how you write it, it's stress-provoking, anxiety-provoking, emotion-provoking, and extremely common as we get older. And I'll tell you more and more about it. Okay, the definition is it's defined as the inability to achieve or maintain an erection for any reason. And it would probably be a better definition would be a persistent inability to maintain or achieve an erection, probably lasting 3 months or more. Any one of us can have erectile issues at any given time. You drink too much, you're tired, stress at work, and it happens 1 time, 2 times. It's not that big a deal, but if it's, am I not close enough?
Yeah, you can actually pull that out if you'd rather hold it too.
How about that? Okay, maybe I'll pull it. Okay, so I thought my booming voice would have been, apparently not. So, as we get older, it's more common. Now, in a younger man, in their 20s, it's exceedingly rare. As we get older, it gets more and more. And by age 65, it's at least 20%, and I think realistically more than that. So, before we can talk about erectile dysfunction, we should think about how complex male sexual arousal is. It's not that straightforward. It's not like you push a button and you get a response. We're not flicking on a light. There's a lot of things that have to happen at the same time. The brain has to be involved, the emotions have to be involved, there's a visual stimulus that comes from the eyes or a tactile sensation, and it has to be processed in the brain, shoot down the spinal cord, go towards the penis, stimulate certain nerves which release chemicals that stimulate blood vessels to open up, relaxation of muscles in the penis that open them up, becomes engorged with blood, and an erection occurs. So there's a lot that goes on. Anytime there's a machine where there's a lot goes on, a lot of things can go wrong. So who's at risk? Obviously, as I said, as we get older, the risk is higher. Medical conditions, tobacco use, being overweight, lack of exercise, drugs and substance abuse, all of the things that Dr. Montevari was talking about, I will echo in my talk today and probably repeat them over and over again. So the better we can be, the less likely we are that we will encounter erectile dysfunction, at least not early. Okay, so again, most of the time, the causes are physical. I'll review those in a minute. And less often, it's psychological. And that's what the books say, but I'm not sure that's entirely true. I think psychological causes are much more common. And we're not talking about depression or psychiatric illnesses. I think stress, our everyday life, you know, you're tired one day, things don't work. Now the next time you're about to engage in sexual activity, it's in the back of your mind, gee, I wonder if it's going to happen again. So that performance anxiety is a huge source of repetitive issues with achieving and maintaining erection. And because it's October and it's baseball time, the best analogy I have is the batter that strikes out, and next time he goes up the bat, he's concerned he's going to strike out again, and then so on and so on. Then he hits 1 home run, then he's on a hitting streak. So that is a huge psychological aspect of what happens, whether there is or is not any organic medical disease. So again, the same things: obesity, diabetes, high blood pressure, high cholesterol, heart issues, and neurological issues like Parkinson's, multiple sclerosis, spinal cord injuries, and many of the treatments that we perform for prostate cancer and some of the prostate cancer drugs also cause erectile dysfunction. So psychological factors, as I said, stress, depression, anger, relationship issues are probably one of the biggest that we as urologists don't tend to deal with very well, I don't think, but we're open to listen. So, how do you prevent it? Well, try to not become overweight, all the stuff Dr. Montevari was talking about earlier. And if you are overweight, try losing weight. Stop smoking. These are relatively They're not easy to do, but they're easy to understand as to how they're hindering sexual performance. Minimize or avoid alcohol or illicit drugs. Exercise regularly. Reduce stress, anxiety. Hopefully Dr. Sethna will give us some direction on how to do that. So the same messages everyone else is giving you. Talk to your doctor. Bring in your medications. Discuss your whole medical history. Your family doctor is probably the best person to start with. They know your history best, and you can usually more openly share with them what's going on and get their direction. So what do we do as doctors? Well, the good history is probably the cornerstone of what we do. I think spend the time, understand what's going on with the patient, all their health issues, all their medications. Are there medications they're taking that may be hindering their sexual function? Blood pressure medications are notorious. Prostate cancer medications are notorious for that. We do, of course, cholesterol testing, blood pressure testing. We do hormone screening with testosterone checking blood sugar. You'd be surprised the number of times I pick up someone who's actually diabetic who never knew that they were diabetic. And so we do that cursory screening, but that can be probably better done in the family doctor's office. Sleep apnea, we've had that mentioned before. Not only can it kill you, it also has a very negative effect on sexual function. So how do we manage it? Well, the first step, as with many health issues, is lifestyle management. So reverse all of the things that make you a risk factor for developing erectile dysfunction. Low blood pressure, diabetes. It's possible you speak to your family doctor about altering your blood pressure or other medications that may be negatively impacting sexual function. Exercise regularly. Quit smoking. And Dr. Monaver again pointed out to us the parameters of what type and how much exercise we should do. So, getting to the meat of it. The pill, right? The little blue pill that came out, 15 years ago now, revolutionized how we manage erectile dysfunction. Yeah, it's a hassle. Yeah, it's a pill. Yeah, it has side effects, but it really works extremely well. And it has cousins. Viagra was the original. There's now Cialis, Levitra, and Staxin, which is really a cousin of Levitra. It comes in a little, you slip it under your tongue form rather than having to swallow it. So, which is better? It depends on the circumstances. Viagra is an excellent drug. It's ingested, preferably on an empty stomach. It takes about an hour to get in your system, but it requires sexual stimulation, sexual activity in order for it to work. No matter how much you like baseball, if you're watching the baseball game, nothing's going to happen. So all those triggers that I was talking about earlier need to be involved, okay? Cialis, again, also a great drug. The difference with Cialis and Viagra has a half-life of about 6 hours, which means that the potential for the better quality erection is approximately 6 hours, whereas Cialis has a half-life of approximately 36 hours, which means day and a half, almost 2 days, the potential is still there. So if someone's going to have a good time for a weekend, Cialis might be a better drug. It's not quite as potent. Levitra unfortunately was marketed poorly, and it's a wannabe drug because it works exactly the same way as Viagra does, and it never really, kicked off. As I said, they're simple to use. They have a few side effects: flushing of the face, headache, back pain, upset stomach, but most of them are quite tolerable. The kicker is you cannot use them with nitrates. Nitrates are drugs that are used for, like the nitro spray, for people with chest pain, with heart disease. Very dangerous, a combination of which basically you die. And if you remember way back when Viagra first came out, there were a lot of deaths, and it was probably because we as physicians didn't know how to use the drugs correctly. Now we're hopefully a lot smarter. Now, if the pills don't work, actually one other comment, no, I'm going to pass on that. So if the pills don't work, there are penile pumps. A penile pumps, just as it shows in that diagram on this on the, there we go. Try that again. Anyway, it's a vacuum device. So it's called a vacuum erection device. Basically, it's a cylinder that's placed over the penis, pushed up against the abdomen here, and there's a pump, either electric or manual, creates a negative pressure, which means a vacuum. So you're sucking all the air out of that vacuum. Essentially, you're sucking blood into the penis. It requires a tension ring around the penis to be placed afterwards in order to maintain the erection. Otherwise, you remove the suction, nothing happens. So it's not bad. It's successful about 60% of the time. Requires a highly motivated patient. It is somewhat cumbersome. It does kind of throw a monkey wrench into the spontaneity. There might be a little bit of bruising around it if the suction is too hard, but nothing dangerous. Next, self-injection. This scares the crap out of everybody in my office when I bring it up. It's a tiny little needle. It's what diabetics give themselves insulin with every day, and yet the idea of placing that into the shaft of the penis, not the head where it's sensitive, but into the side of the penis where the skin is the same as skin anywhere else, freaks everybody out. But it's highly effective. It probably works about 80 to 90% of the time. There's all sorts of different drugs. There's alprazolam, phentolamine, papaverine, and there are combinations, bimix, trimix, of any one of these. They're highly successful, as I said. They work within 10 minutes. The erection lasts, depending on the dose, somewhere between 30 minutes and an hour, okay? Now, unlike the commercials for Viagra or Cialis that you hear, if you have an erection over 4 hours, call your doctor. I'd be calling everybody, calling my MP, calling my best friend. You're not going to believe this. So, unlike Viagra and the oral medications, where I've never heard of a single case, and speaking to urologists for the last 15 years at meetings and whatever, no one's ever heard of a case of an erection lasting more than 4 hours with the pills. That does unfortunately happen with the injection. It's called priapism. It's very painful, it's very dangerous. So the way we avoid that is a graduated dose. So we start with a very low dose. Hopefully it won't be successful, and then we'll know that that's a safe dose and go up from there. There can be some pain at the injection site, might be a little bit of bleeding and bruising at the injection site, but really well tolerated. Urethral suppository, that's called MUSE, Medicated Urethral System for Erection. It looks like a little syringe, but it's not sharp, it's blunt. It's placed into the end of the penis. There's a little pellet like a grain of rice at the end of it. You press the little button there, it releases the little pellet, and the pellet basically dissolves in the urine in the penis and gets into the shaft of the penis and you get an erection. Well, it takes about 50 minutes for it to work, lasts approximately 60 minutes. There's a little bit of pain with it, and there's a little bit of burning when you pee afterwards, but again, it works 60 to 70% of the time. Penile implants. So the last ditch, excuse me, if we've tried everything else and nothing has worked, we put in a penile prosthesis or implant. So basically it has a fluid reservoir, it has the shaft, inside the shaft, the pump and fluid channels to communicate. So you pump it up, basically it goes from this position to this position, you're pumping fluid from the reservoir into the shaft, into the cylinders to get an erection, and you press that button, bottom square part to bring it down. There's a lot of risk associated with it. It's an operation, there's risk of infection, there's risk of equipment malfunction, but as a last-ditch effort, there are a lot of happy guys out there with it. Okay? Non-medical therapy. You'll read about this on the internet. People will send you emails, they'll sell you stuff. Watermelon, nuts, anything that's high in zinc, garlic, cayenne pepper, various supplements, ginkgo biloba. I don't think any of them work, including shockwave therapy for the penis. So basically, someone's going to stand there with this device and shock. Now, it's the shockwave, to be fair, it's not electric. It is an energy pulse that stimulates blood vessel production. And not to get overly scientific about it, the idea is great. It doesn't work practically because the problem isn't 1 or 2 blood vessels or what you can develop in 5 or 6 treatments, new blood vessels. The problem is the entire lining of the penis, which has a gazillion little tiny blood vessels. That's where the problem lies. And it's the lack of relaxation of those muscles, of those blood vessels that don't open up, that don't fill with blood, which causes the erectile problem. So repairing a few little blood vessels with this doesn't fly. It just doesn't work. There are no studies. Okay, so the last word. Basically, prevention is best. Lifestyle, exercise, all the same things we're all been telling you. Most treatments are very successful to varying degrees. Talk to your doctor. And I think this happens very often. You know, as physicians, we're not sure we want to address the problem. As patients, we're saying, geez, if he asked, I would just tell him all about it. And so I think we all can learn from the open rapport that we can get if we just open up, share, and talk to your doctor. And final word, okay?